multi-drug resistant gram-negative bacteria. It's a nightmare for each and every intensivist, and it presents many challenges, especially in critically ill patients. It also almost invariably reduces the probability of adequate empirical coverage with possible unfavorable consequences. To discuss all this, I have Dr. Subhash Todi with me, Director of Emory Hospital, Kolkata. Dr. Todi, welcome to podcast ICCM.
Thank you. Go ahead, Bharat.
Yeah, sir. So first question, sir, I would like to have your take. How
Mhm.
common is this multi-drug resistant gram-negative infections in India? What is your take on that?
As we are all aware that gram-negative infections are the predominant ones, though we have our shares of gram-positives, but I would say mainly hospital-acquired infections are predominant. I think almost 70-80% of hospital-acquired nosocomial infections are of gram-negative in nature. The rest are gram-positive.
So, sir, we seeing so many gram-negative resistant infections. I mean, multi-drug resistant infections. What are the various resistant mechanisms of it? I mean, why is it building up and it's becoming a major problem?
Because as we all know, there are different resistance mechanisms of the gram negatives. To start with, there are ESBLs or extended spectrum beta lactamases, and ESBLs are of many varieties, of which SHV and TEM are the ones which are very important in our country. Then there are carbapenemase production, of which OXA48 is also becoming more and more important in our country. And lastly, there are metallo-beta lactamases, of which NDM, the New Delhi metallo-beta lactamase, is the predominant one. So basically, when we have to cover empirically for resistance mechanisms, it's ESBL, OXA, or it has to be NDM.
Sir, so you named these various strains MDM, OXA48. So I will also like you to tell us how do we recognize this and how do we find out what strain is it? What are the various methods of looking for it?
Ideally it has to be through genotypic methods nowadays with the rapid diagnostics, the multiplex PCRs, which can be done directly on the specimens like sputum, or through any cultures. Once the growth is there, then one can do variety of this PCR test that tells us whether it is going to be one of these resistance mechanisms. But many places do not have access to this PCR test. So from phenotypic, if a bug is resistant to cephalosporins but sensitive to piperacillin, tazobactam, and carbapenem, chances are very high it is an ESBL producing organism.
Okay.
On the other hand, if it is resistant to cephalosporins and piptase and carbapenems, then it is a OXA or NDM. Now, by phenotypic, it is very difficult to differentiate between these two. But what we have found over time, that if the MIC of carbapenems are kind of a borderline high, so they are in the resistance range but not that high, then the chances of OXA becomes very high. On the other hand, if the carbapenem resistance is very high, then it is most likely is an NDM variety, especially if it is resistant to other like amikacins and aminoglycosides, quinolones. It's multi-drug resistant, then its chances are NDM. So we can have some idea of resistance pattern by phenotypic. Another way, because this phenotypic and genotypic are mostly after the cultures. Question is, if we have to do empirical therapy, how do we choose? By and large, Enterobacteriaceae, mainly E. coli, still 70% do have only ESBLs. Klebsiella in our country will have OXA and ESBL, whereas Acinetobacter will have NDM. Pseudomonas will still have ESBL and OXA. There might be some NDM. So depending upon the kind of gram-negative we are suspecting, empirically we can have a reasonable idea which resistance mechanism we need to cover.
So, sir, I mean, you told us very clearly and nicely how to identify it, either through the different various stats or through the culture report as well. So, how do we go for the final approaches? How do we suspect those and we go for the final treatment? And what should be the treatment approach for various strains, as you said, or we talk about the CREs, carbapenem-resistant Acinetobacter, DTT, Pseudomonas. So, what could be the various approaches for that? Those.
Once we have a patient, first of all, we need to see whether it is a community acquired infection. See, we are talking about patient getting admitted in ICU, or is it a hospital acquired infection? As severe community acquired infections, we have to have a syndromic approach. So in a case of pneumonias or in case of abdominal infection, by and large, we would still be treating it as an ESBL. We won't be, until unless the patient has been exposed to carbapenems in the past or had multiple infections in the past, had multiple antibiotics, multiple hospital visits. There we might want to go ahead and treat as a even carba resistant organism. So the first thing which is coming up is an ESBL organism, community acquired infection, whether we should be giving piperacillin tazobactam or whether we should be giving one of the carbapenems. The present guidelines would suggest that carbapenem are better than piperacillin tazobactam. Even both of them might be sensitive to ESBL so far as clinical outcome is concerned. But the consensus is, if you have empirically started somebody on piptase and the patient is clinically improving, and later on you have got a bug which is ESBL, you continue with piptase provided the infection is in the urinary tract. But the current guideline is, if it is a non-urinary tract infection, even if I have started on piperacillin tazobactam, patient is clinically improving, I probably should switch to carbapenem because they are clinically have got a better cure rate. So, but we might de-escalate it later to another like piptase later on. So that is on the ESBLs. So far as the carba-resistant infections are concerned, we have a few options. If it is an OXA48, the ceftazidime avibactam, which have recently come into the market, have got good sensitivity against OXA48, and most of the Klebsiellas will have OXA48. So ceftaz-avi will cover both ESBL and OXA48. So if I have a patient whom I think might have a resistant mechanism but not NDM, in the sense that he was not very heavily exposed to too many antibiotics in the past, I might choose for ceftazidime avibactam. Now, if the cost prohibits or if there are other issues, rarely a higher dose of carbapenem in an extended infusion, like 5 or 6 grams of meropenem over an extended infusion, can get us away with ESBLs and OXA48, which has got a borderline resistance, borderline MICs in the resistance range. So far as the NDMs are concerned, which are mainly with Acinetobacter, Acinetobacter is very difficult to treat infection. And as you have just heard, that I didn't talk about colistin or polymyxin B for your carba-resistant Klebsiellas and others. Yeah. By and large nowadays they are not given very high sensitivity pattern. Even the antibiogram will call it intermediate. So if possible, if there are alternative, it is better to get away from colistin and polymyxin. Now, so far as NDM is concerned, so far as Acinetobacter, the present consensus is the backbone antibiotic in Acinetobacter should be sulbactam, because it has got a very peculiar action against Acinetobacter. The Acinetobacter usually doesn't get resistant only because of NDM, but because of many of the protein binding, penicillin binding proteins in the cell wall which get mutated. And sulbactam works against this cell wall mutated protein binders. So sulbactam should be the backbone, even if it is resistance in the phenotype. A higher dose of sulbactams, around 6 to 8 grams, and usually a double or even a triple therapy needs to be given for Acinetobacter. So sulbactam and minocycline has got a good coverage for NDM Acinetobacter. And if a patient is very sick, then you can cover it along with colistin. But sulbactam and minocycline are good coverage for Acinetobacter. So I think that is how we should cover for ESBLs, piptase or carbapenem. For OXA48, it is usually ceftazidime. For NDMs, we have to, for NDM Acinetobacter, we have to give your sulbactam and minocycline plus minus colistin.
So yeah, very nice tips for the day-to-day activity and how we should be approaching and treating, especially for the Acinetobacter. Sir, would you like to cover anything about Pseudomonas?
Even the Pseudomonas, the Klebsiella is said to be the new Pseudomonas nowadays, because at one time we were very afraid of Pseudomonas. But now in India, the Klebsiella strain is a very peculiar strain. We think that MDR bacteria are more virulent, but usually they are not. Most of the sensitive bacteria like pneumococci, MSSA, meningococci, they are much, much more virulent than MDR bacteria. But there is high mortality because of MDR, because we don't cover that right empirically. Except Klebsiella is a very peculiar organism. It has got a strain ST231 in India, which is more virulent and more resistant. And so that is why it becomes very difficult to treat. Whereas Pseudomonas, nowadays the sensitivity to even carbapenem is kind of gradually increasing. And that's why we might treat it with carbapenem or with ceftazidime, maybe Bactam, if we think it is an OXA. Pseudomonas do have their NDM as well. So it depends upon where you practice. In a hospital acquired infection, if it is a patient, you need to know your antibiogram of Pseudomonas and see how they behave. So I think overall Pseudomonas I would treat with ceftazidime if it is patient is not a very high risk, or we have to have a combination of even we might have to use colistin for these patients.
Sir, it was very nice talking to you and very crisply explain how do we diagnose it, how do we go about it. It was as always good talking to you. Thank you very much, Dr. Todi, doing it for us.
Thank you.
Thank you, ICCM. See you again with some other topic. Yeah. Bye.
Thank you. Thank you, Bharat. Thank you.
That's all for today. ICCM podcast is production of Indian Society of Critical Care Medicine. Thanks for listening. Stay safe. See you again.